everyone present here. I'm Ashwini from CGS Medical College and KM Hospital. I'm in my final year of MBBS. Around 4.5 years in and out of the wards, I realized that most of the people in the wards can be divided roughly into two categories. One consisting of highly intellectual, well-educated doctors, and the other section is of illiterate, ignorant patients who have absolutely no idea about the disease or the kind of treatment they are receiving. Why is it so? I thought, isn't this an information age? There is no dearth of information that is available. In spite of excessive outsourcing of information, how come the patients are still steps down the ladder of information? The pathos is that it's a pure chaos. The Right to Information Act is in, but how do we exercise it? In the face of current situation of the medical interns and doctors getting beaten up and the ongoing strike to secure security, it's a state of utter shame. And it just indicates a dismal state of affairs. But what is the root cause of all this violence? It is the dissatisfaction at the grassroots levels. It's basically an imbalance between the expectations and the actual effectiveness of the therapy that is being provided. Effective communication is the need of the day. It is important at this juncture that we as doctors state clearly what lies in the realms of medicine, what we can do and how it can be done, and what is best left to destiny. And this will definitely go a long way in building the trust and the respect towards the doctors. What needs to be provided is accurate, impartial and perfect information. Too much or too little could cause equal harm. What I mean by too much is, for example, a patient of connective tissue disorder in whom giving a oral prednisolone therapy could be life-saving. It is unwise to tell him about all the major, minor, short-term, long-term side effects at one go. It could just scare him off the treatment. Quite on the contrary, a patient, a woman in the childbearing age group who is being on tretinoin for treatment of acne, it's very important to tell her to stop the drug few months before conception. Birth of a congenitally malformed child, in this case, would be a huge moral, social and a medical legal issue. With this widening gap between us and the subjects, streamlining of information could help us to bring both the ends closer. At this juncture, what I would like to suggest, a working solution to this problem at hand, which could grow larger, is medical counseling. It could either be in person or by creating an excellent database by the treating physician or the doctor himself. And this could really help the patients to make a truly informed choice and have practical expectations from the doctors, and the compliance would definitely go up several grades. The ideal scenario would be where a patient and the doctor meet face to face and they discuss the problem, where the patient gets to ask all the queries, all the concerns, and the doctor reciprocates, explains him the kind of therapy that is being given or the various choices that he has and the kind of compliance that is expected. After this, both of them reach an unanimous decision which has been well debated, well thought upon, and bring about a treatment. But this team approach is humanly possible only in the projected doctors to few patients ratio which has been given in our social books, but not in the real world. So what can get close to this is, in the same forementioned plan, replace the doctor for actual therapy and substitute him with a medical counselor. So who is actually a medical counselor? He could be a doctor in the making. He could be a postgraduate student, say in his first or second semester. He could pose as a medical counselor for a few months. Being a doctor himself, he could, being knowledgeable about the disease, he could tell the patient about all the pre and the post-treatment care that has to be taken, the follow-up, and the long-term and short-term picture about the whole disease, and help him through the process of coping with the disease. And being a junior doctor, he can be supposed to be more available and accessible to the patients as compared to a senior doctor who is thought to be very busy. Considering he is a budding doctor, he can also supposed to be more sensitive towards the concerns and worries of the patient. Due to the opportunity of interacting with such a huge number of patients in the early lives of his medicine, and he's the one who would be actually sensitized to the problems of patient and what expectations they have from the doctor, because through the queries of the patients, and if put into practice, he can definitely become a better doctor, because it is to the patients to whom we ultimately belong. So why I'm saying this is that the patients need to understand that instead of just going searching on the net or rampantly searching for information, they could ask for a medical counselor who could This is the closest it could get to being updated by a treating physician himself, and they could approach him for solving their queries. So what do we as doctors gain out of this? As a medical student, I can definitely see an increase in the number of postgraduate seats because a doctor will have to be spared for this job. At the same time, both doctor-patient communication will lead to better understanding of the disease, of the treatment being well accepted, and the compliance being better. For example, in a cardiac failure patient, it is extremely important to tell him the importance of a salt restriction diet, which is just not an auxiliary way of treating the disease. It's in fact the mainstay of the treatment. As a doctor-patient is a team approach in fighting a disease, it's very important to take the patient along with you in this process and to adequately inform him wherever required at whichever junctures. For example, what is the main cause of treatment failure of the disease of India, tuberculosis, in spite of the well-crafted intelligent dots therapy? It's the defaulters. And why are there so many defaulters in spite of free treatment in our hospitals? It's because the patient themselves do not know the essentiality of continuing with the therapy after fever and cough goes down at the end of around 2 months. So this has to be told to the patient, and this just leads to relapse of the disease, failure of treatment, resistance among the organisms, and the whole picture just becomes so much more complicated and the disease becomes incurable. At the same time, it's much more easier to communicate with the patient who is being well informed than talking to an ignorant patient. So in a private setup, what can be done is you can adopt a less ideal approach of creating a database. So why do I call a database less ideal? For example, while you're treating a patient with cancer with a combined therapy of surgery, radiotherapy, chemo, immunotherapy, it is essential to tell him about the side effects of each of this modality of treatment. But while you're telling him about side effects like the high risk of hematological malignancies following a radiotherapy or a chemotherapy, it has to be finely balanced with the good things about the treatment that you're giving him, the prognosis of the patient, the survival rate of the patient following this, the quality of life that he's going to get after this. And this fine balancing of information is where information therapy cannot displace a human. And this is a dynamic process which cannot be left to the hands of a pre-created database, and hence the role of a medical counselor. But why do the hospitals even need a database? If you go on these search engines like Google or anything, and when you try finding information about the disease, they'll give you a whole array of choices available, right from the obsolete ones to the still under experimental stage kind of therapies. But all hospitals might not have all of them. So in that case, it's very essential for a hospital to have its own protocol which is being documented on the website or on its own database. For example, when a patient with aneurysm comes to a KEM hospital, he is either directed to neurosurgical clipping or endovascular coiling based upon the characteristics of the aneurysm, the size, location, morphology, or the patient's characteristics like the age of the patient, consciousness, WFNS grade, his age, and also the economic state of the patient. So in that case, it is very important to tell the patient why he has been channelized to a particular modality of treatment, because this could vary from hospital to hospital in the same city. In fact, in a given hospital, the patient, every ward, every medical unit has its own way of treating a disease. So a patient who is getting admitted in different wards could actually receive different treatment. And this whole scenario just leads to confusion and lack of trust in the doctor. Even in the private setup, every doctor has his own P-list of drugs or a personalized list of drugs or his own personal inclinations towards a particular therapy. For example, I myself have heard a doctor say things like, oh, salbutamol works much better for my patient than terbutaline does. But right in the same city, in some other part, another doctor will be prescribing the other drug. So a patient who shuffles between doctors, which is quite obvious in today's days, it just leads to lack of trust in the best management or the best line of therapy. So this confusion can be avoided. Any therapy can be chosen until and unless it is being justified to the patient. In this age of over-the-counter medications, for example, fluoroquinolone is one of the most widely used antibacterial drugs. So it is of no problem till it's given. For example, if you prescribe it to a mother for any kind of infection, it is very important to caution the mother against its use in a child who is in the developing age group because of the side effects on the developing joints in the child. So she has to be particularly told about this, and the same medicine can be used in the adults, the remaining adults in the family, without any problem. So hence, dispensing of information is extremely essential. Why I am trying to say this is because the patients have to realize to access trustable databases which are being created by the hospital themselves or by a doctor who is treating them instead of just widely going searching about information on the net. And this explains the importance of giving information to a patient. How else do you expect a patient with sore throat to take an intramuscular penicillin therapy for so long or throughout his life? How else do you expect a patient with cirrhosis to maintain a salt-restricted diet for the rest of his life? How else will a diabetic patient be on a strictly modulated exercise regimen or change or plan even the smallest meals of his day unless he's told the importance of this? And how else do you expect your treatment to work for such a patient and patient to be happy with you? Hence, whichever way is possible, if for the optimal use of the information and the medical knowledge we have, it is very important for the approach to be two-way. And only then it can go down equally well on both the parties. So that's all I want to say. Thank you.
A very good point you brought out about this need for a medical counselor, trusted databases that are very like, you cannot write off a database which is actually very important for any patient or any hospital. But like you said, trusted database in the hospital itself have credibility. That's very valuable and different. When a patient is going to different databases of different hospitals, then again they have a choice. You can make some good choices there. So, good competition, I guess. I mean, you're taking on the whole system actually. But thanks, Ashwini.
I invite my next speaker, my colleague Raghav Arora, to